showing that about 1/3 of patients with severe COVID have blood clots. Another study of 191 patients with COVID-19, half of those who died had clots compared with 7% of the survivors. And levels of D-dimer that were greater than 1,000 were associated with a fatal outcome. So it's pretty clear now that SARS-CoV-2 virus is causing a lot of clots to form in moderate to severe COVID disease. But how is this happening? It's likely a combination of reasons that have to do with downregulation of the ACE2 receptor in the lung alveoli, with a subsequent shift towards having more angiotensin II in the lungs and less angiotensin 1.7 and less angiotensin 1.9 in the lungs. And when this happens, this leads to more cytokine storm with more inflammation, more constriction of pulmonary arteries, and more clots that develop. That in turn leads to more endothelial dysfunction in the capillaries that surround the alveoli. Also, there's evidence that the virus attaches to the ACE2 receptors of the endothelial cells that line those capillaries, which further propagates inflammation and clotting. And in the cytokine storm that develops there, RANTES, a chemokine, binds to the CCR5 receptor of CD4 and CD8 lymphocytes, and that causes those lymphocytes to infiltrate those areas of inflammation, and in doing so, further contributes towards the inflammatory reaction. This is why we're seeing low levels of CD4 and CD8 lymphocytes in severe COVID. Endothelial damage can also lead to the development of antiphospholipid antibodies, and these antibodies are bad because they trigger the formation of blood clots. And that's why patients who have clots with the diagnosis of antiphospholipid antibody syndrome, they need to be on blood thinners. Also, 11 out of the 12 patients in the study had underlying heart disease and were obese. These are known risk factors not just for cardiovascular disease, but also known risk factors for endothelial dysfunction and are known risk factors for COVID. The endothelium is more susceptible to damage based on cardiovascular risk factors, such as men age 45 or older, women age 55 or older, smoking, high blood pressure, high cholesterol, diabetes, obesity, and lack of physical activity. So the big takeaways from the findings in this study is that most people who die of COVID, it's primarily a lung problem, either related to inflammation with ARDS and or blood clots. Even though blood thinners are not a cure for COVID per se, they do have the potential to save lives. The hard part is figuring out who is likely to develop clots and who should we give blood thinners to, and which blood thinners should we give, and should we give high doses of blood thinners or just the low dose prophylactic doses. But what about patients without moderate or severe COVID? Should they take a blood thinner or maybe a low dose blood thinner? Or should they take an antiplatelet medication like aspirin, either 81 milligrams of aspirin or 162 milligram dose or 325 milligram dose? Or should the general public take a low dose aspirin like 81 milligrams in order to help prevent blood clots from forming if they do get COVID? Or should it just be certain people in the population who are at higher risk of getting severe COVID? Should they take aspirin? These are the questions we don't know the answers to at this point. It's going to take a lot of studies to answer these questions, because not only do we need to know that there's a benefit in doing so, we have to know that these benefits will outweigh the risks, such as the risk of bleeding.